Welcome, everybody. My name is Aviva Ariel Donjas, and I am the health psychology intern at Jesse Brown VA, and also the student chair of the Society for Health Psychology, Division 38. On behalf of Northwestern University's Feinberg School of Medicine and the Jesse Brown VA, I'd like to welcome you all to our 2018 Health Psychology Seminar Series. We have a great lineup of health psychologists, including today's speaker. And as a reminder, it will be every Wednesday at 3:30 p.m. Central Time from now through November 14th. For those of you who are streaming online, we're so glad to have you joining us. If you'll go into the chat box on your blue jeans, let us know where you're calling in from, either your school or your city, and just so we can get a sense of who's tuning in. You're also welcome to type in questions throughout today's presentation, and we'll make sure that Dr. Williams has a moment to see them before the end of the time so she can answer those. And if you have not already muted your microphone and camera, please do so. And I can do that for those who have not done that yet. So anyways, I am honored to introduce Dr. Adrienne Williams. She is the Director of Behavioral Science and Associate Professor of Clinical Family Medicine at the University of Illinois at Chicago College of Medicine. Dr. Williams completed her undergraduate degree at Yale University, her master's and PhD at Duke University, and her internship at the North Florida South Georgia VA Medical Center. She completed her fellowship in health psychology, behavioral medicine at the Consortium for Advanced Psychology Training at Michigan State University. Dr. Williams specializes in behavioral medicine, sexuality and gender, and brief evaluations. And today we're thrilled to have Dr. Williams present on teaching the patient-centered pelvic exam. So without further ado, I'm just going to fix something real quick and then we're good to go.
And how will I see the question?
I will help you check them at the end.
Awesome. Thank you so much for having me. I'm really excited to teach this. We only have an hour for this. Usually when I am teaching this, I am teaching family physicians. I've also taught internal medicine physicians this, sometimes attendings or faculty, and sometimes I am teaching residents. I do teach this at least once a year, but I have taught it more than once a year when I'm invited to different residencies to provide this training. When I do provide the training, it's usually an hour to an hour and a half. I will be doing some of the training that I actually give to physicians, but then I will also be adding in things about how to teach physicians, especially when you're trying to teach physicians something that has historically been done only by physicians and not by psychologists, because of course you can get some kind of backlash where somebody will be asking, you know, why is a psychologist teaching me how to give a pelvic exam? So how to overcome some of those barriers. So that is where we will start off today. So my objectives for today are that I want to just review the slides on patient-centered pelvic exams with you, the slides that I actually go over with the residents, and then I'll also be discussing the key points for teaching physicians about physical exams. So my background is that I have a specialization in sexuality. I actually started this when I was in high school. I started working with Planned Parenthood and learned how to do peer support for issues of sexuality and gender. I continued that interest throughout my schooling. And so that's kind of where this idea came from. I was already on this path and I was already treating patients for sexual dysfunctions. And I frequently had heard complaints from friends and patients about their pelvic exams. And so I knew that this was kind of an area that people hated and that people felt was problematic when going to their doctor, but But in working in medicine, since I have been working in family medicine for the past over 10 years now. When I started this, I've been working in family medicine, and I saw that on the physician side, pelvic exams were not something that was generally considered a problem. And in fact, I looked up pelvic exams, and I saw that it was listed as a procedure with absolutely no risks. Now, from the psychology side and having treated sexual dysfunctions, I knew that pelvic exams had been listed as a risk factor for certain sexual dysfunctions, especially vaginismus and dyspareunia. Vaginismus is an involuntary contraction of the outer third of the vagina, and dyspareunia is pain during sexual intercourse. So for those of you who are listening who may not be aware of what pelvic exams are when doctors examine the external and internal parts of the vagina. Throughout this presentation, I will often use the word women. When I say women, I am using that term expansively. I mean women, I mean trans women, as well as people who are born with vaginas who do not identify as women. Seeing that basically on the physician side, they pretty much saw that people thought that there was no problem with this. And from friends and patients, hearing that people felt like there were a lot of problems with pelvic exams, I figured this might be an area that I could teach physicians from a patient-centered perspective. Of course, I had also had my history of my own exams, and so with my N of 1 study, I saw that some physicians, would tell me one thing or would act one way during exams, and other physicians would tell me something completely different or act completely differently. And so with that, I did see that there was, at least from my observation, a difference in how different physicians performed this exam, which meant that there was also an opportunity here for an intervention with physicians. So this is the beginning of the slide that I've generally used. We used to call this improving pelvic exams and reducing iatrogenic effects, decreasing distress, and enhancing the doctor-patient relationship. This is how I originally proposed this and how we originally presented it. My recommendation here in terms of teaching this to physicians is use the terms that are most popular at the time. So at the time that this was created, those were really big terms. I have now moved to patient-centered pelvic exams because right now everybody's trying to be patient-centered. And so when you sell it that way, people are more likely to listen. The next teaching point I have here is you might want to partner with a physician. So basically, if you have any area of interest, so like I said, I had this area of interest of sexuality, and I just saw an opportunity. That means that each of you, if you have an area of interest, then you can also find something in that area. Even if it is within medicine and you don't feel like you have a lot of medical training, you can still make a difference in that area. And if you partner with a physician, that can also help to fill in some of those gaps. The objectives that I let the physicians know is that they will be learning potential adverse outcomes of pelvic exams. I do start with that just to emphasize the fact that there are adverse effects to pelvic exams. We're going to discuss techniques to improve exams, and that we're going to develop a strategy for implementing techniques into practice and training. Now, there's a few reasons why I do this. First of all, in psychology, a lot of times we start off by discussing like the theory behind something. Well, when you're teaching physicians, because they are primarily clinicians, they are often most interested in what to do and not necessarily how to think about it. How to think about it is something that psychologists love. Physicians are often thinking like, well, what do I do when I'm in this room with this patient? So all of the objectives are much more specific to those types of things. I usually also inject here, I ask the physicians, how did they learn about pelvic exams? And then we talk about how speculum exams are really commonly performed, but there's only a little bit of time spent on teaching them in medical school. And usually the focus is very physician focused. The focus is on finding the cervix and not necessarily on on paying attention to the vagina leading up to the cervix or the woman that's encompassing the vagina. So that's one of the things that we definitely, that people usually laugh at, and I'm just like, yes, but that is one of the things that's going to be really important when you're doing patient-centered care, is not just paying attention to the part of the body that you are trying to find. So teaching point, don't start with theory. Then I use a case example. So the case example that I use is actually a real case. So that is my teaching point here. If you can start off with a real case, it will start to let the physicians know, like, this is something that I could really see in my own clinic. This is a possibility, and so I really need to pay attention. So the case that I used was of a 35-year-old woman who I saw who had been referred to me for severe vaginismus. She had presented to an emergency room when she was 14 with abdominal pain. And at that time, it was standard to do a pelvic exam on any woman who had abdominal pain. Now, she was 14. She did not understand what was happening to her. They didn't really explain the speculum exam very well. They did not explain that they would be placing a medical instrument in her vagina. So when they actually did it, she experienced a lot of pain, and she had a very strong anxiety reaction. And in fact, they actually did end up having a nurse come in to try to hold her down so that they could complete the exam. This is in the literature referred to as a speculum rape. It is rare, but it is something that probably those physicians did not realize that they were doing at the time. They probably thought that they were giving the fastest care and doing the most effective job that they could. Now, as a result of this, she was extremely avoidant of pelvic exams after that. When she got married, now one of her goals in life was that she wanted to get married and have 6 children. She got married in her early 20s, I think around 22. And by the time I saw her, she had been married for over 10 years. At that point, she and her husband were having sexual contact about 3 times a week, but she had such severe vaginismus, again, that's the involuntary contraction of the vagina, that she was not able to achieve intercourse. And as a result, she had never been pregnant, and now she's in her mid-30s. So she is at this point not able to reach her life goal of having 6 children. She also had never been able to achieve a pelvic exam without being sedated or sometimes under conscious sedation. And they had even tried putting her on Valium and things, but she still would have full panic attacks anytime she was around, anytime they asked her to do a speculum exam. So I bring this up to the physicians because it also shows, while we're being patient-centered, of course, we're showing this patient who had severe outcomes from a pelvic exam, so giving them the example like, yes, there are iatrogenic effects, but also saying from the medicine side, if you do a bad job, they're not coming back for any more pelvic exams. So if you want this patient to come back for routine medical care, it's a really good idea to make sure that these pelvic exams are tolerable and not traumatic. So then we go through the iatrogenic effects. We talk about pain, discomfort, and how pain is actually different than discomfort. I talk here about how pelvic exams should never be painful. And so for some of you that are listening, you should take this into account for your own experience as well. Pelvic exams should never be painful. If a pelvic exam is painful, it is painful for one of 2 reasons, and 2 reasons only. Either the provider is doing something wrong, or it's a positive finding and it needs to be evaluated. Besides that, there should only be a level of discomfort. So a discomfort, and I tell them, explain to your patient how it's going to feel. It should feel like an uncomfortable pressure in the lower stomach, but that it should not be painful. So you could have pain, and if there's pain, that is considered an iatrogenic effect. They could have embarrassment, powerlessness, strained doctor-patient relationship, traumatization, as we saw in the case of Katrina, or re-traumatization. In fact, 43.5% of childhood sexual abuse survivors experience memories of abuse during gynecological exams. And so this is something that is really important and something that we can have a strong effect on. We already talked about vaginismus, which can make vaginal intercourse difficult or impossible. Dyspareunia, which is pain during intercourse, or apreunia, which is inability to have intercourse. And as we talked about before, the avoidance of future medical exams. So before you get into the room with a patient, there are physician-related factors that should be checked in order to give the best patient-centered pelvic exam. So if the physician has a discomfort with discussing sexuality, that is something that the physician is going to have to work on, and we talk about ways of working on that. There is generally a limited time to establish rapport. Medical visits are typically 15 to 20 minutes, and this might be the first time that you're meeting a person. There could be cultural factors, religious factors, or myths and attitudes. Some of the myths that we go over are like the myth that we just talked about, that pelvic exams sometimes hurt and there's no way to get around it. Women who are overweight or obese will always need a large speculum. I usually emphasize here, body size is not correlated with vagina size any more than body size, than somebody who's obese, than a male who is obese is that's going to correlate with his penis size. It is not relevant. So a lot of times people will automatically go for a large speculum if they have an overweight or obese female. The myth that it's better to hurry up and get it over with if it starts to hurt, that actually increases pain and anxiety. If a woman is sexually experienced, then she should be able to tolerate a speculum without complaining. If a woman has high-risk sexual practices, then she shouldn't have any pain. In fact, the opposite is actually true. Often women who have what are considered high-risk sexual practices, a lot of them have a history of trauma, and thus, which leads to the high-risk sexual practices, and it also can lead to difficulty with pelvic exams. So the next thing that we talk about is the first thing that you do when you go into the room, which is identifying patients at risk. So when you get into the room while the patient is still in their clothes, you go through risk factors. Risk factors will help you to figure out which patients are going to need more time and maybe some more care during the speculum exam, and which patients might be able to have a quicker and easier speculum exam. So we talk about discussing history of sexual abuse and assault with patients. Now, first of all, we start off with stats. So it's really important to use stats when you're teaching anything, and especially when you're coming from outside. So because I'm a psychologist and I'm coming from outside of medicine, I want to make sure to use statistics to be able to back up the things that I'm saying. So about 25% of women have a history of sexual assault. And one of the things that can happen with that is when we're trying to screen for sexual assault, a lot of times physicians will word it in ways like, have you ever been raped, or have you ever experienced sexual assault? Well, one of the problems with that is that 75% of women who have experienced the legal definition of rape do not identify what they went through as rape. So they do not label it themselves as rape, because often it doesn't look like what it looks like in TV or in the movies, but it does actually meet the legal definition of rape. So we talk about how do you actually do this. So again, we're focusing here on what to do in the actual clinical exam. So I go over with them, how do you actually ask them about their sexual abuse or assault. Now, 82% of people who have experienced sexual abuse or assault have said that they've never been asked about that history by their gynecological provider, even though they felt like that was a relevant thing for that provider to know. So the wording of how you would want to use that, to say that, is not to use the label, but more to ask them about the more objective experience. So asking something like, has anybody ever had you do something sexual when you didn't want to? Using that phrasing casts a much broader net and is going to be much more inclusive. Also, please note that I did not use the term forced or made, because that only gets at like the more forcible or violent rapes, and it does not tend to include things like the people who are psychologically coerced, use of incapacitated rapes, like use of alcohol or date rape drugs. Ask the patient if they've had a history of painful speculum exams. This one might seem kind of obvious, but if they've had painful speculum exams in the past, they're at high risk for having a painful exam this time. Ask them if they've had difficulty with tampon use, if they've had any painful sexual contact, and ask them for painful sexual contact in general like that. Don't ask if they've just had painful sexual intercourse, because that, of course, limits it to heterosexual intercourse, and it also limits the type of sexual contact that they might have experienced pain in. Those are the 4 main questions that people are going to need to ask to determine what type of speculum exam they're going to want to give. They should also know if the person is sexually inexperienced. Often, if the person is sexually inexperienced, then they don't need a speculum exam. Sometimes people have just heard, oh, I should get a pelvic exam at a certain age, but sometimes we know we can then tell the patient that, like, they're not actually at high risk right now. If they do need the speculum exam for some other reason, for some other medical reason, then extra care will also be needed in that situation. If it's the person's first speculum exam, definitely more time will be needed. And sometimes people will have inaccurate beliefs about their body or anatomy, such as not understanding the difference between their vagina and their urethra and their anus. And so sometimes those things are going to have to be addressed before even beginning the exam. So the next set of techniques we talk about is then setting up the room. So we're not even at the exam yet, but we've talked about talking to the patient. And as you see here, my teaching point is teach in the order of the medical visit so that they're thinking of each thing that they would do as they approach the patient. So they've talked to the patient, now they're pulling out the materials, and I talk to them about the temperature of the room and how if the room is too cold, not only is that uncomfortable for the woman, but that the woman might, when people are cold, they tend to clench their muscles. If they're clenching their muscles, that will include their pelvic floor muscles, and that's going to make it more painful when they go to insert the speculum. Raising the head of the table into a semi-seated position and having different sizes of specula available. A lot of times, and you see here in the picture, I have different sizes of specula available. Put covers on the footrests, having a handheld mirror in case you need to do education of the patient. So if the patient doesn't know, has never looked at their genitals before, letting them know it's okay to look and teaching them what their own anatomy is. That will decrease the anxiety there. For this part, I also tend to let them know things like the temperature of the room and clenching the muscles. That's a little bit higher level of evidence. Putting covers on the footrests, not really high level of evidence. So as I'm going through the different techniques, I try to also let them know, like, some of these are just suggestions, you might like them. Some of them are higher levels of evidence, and some of them don't have a whole lot of evidence backing, but you just might like to do it. I do also emphasize here to call it a footrest and not to call it stirrups or anything else that can make it seem more awkward or change the meaning of the exam for the person. So the next part is that we go over what an actual speculum is. So this is the part where you might have to do some, if you are trying to teach physicians or teach something that's outside of psychology, you might have to do your extra research. Now keep in mind that you are going to be teaching about things that you are competent in teaching. A lot of times people might try to give the general impression that, like, well, as a psychologist, if you didn't go to med school, you can't, you don't know these things. Well, med school does not have like a copyright on all of the information that is taught at medical school. It just means that they were taught those things. And at this point, I actually tend to know a lot more about specula than most of the med students that I come across. So making sure that you are competent and that you actually have the power and the ability to seek out this education on your own. So there are different sizes of specula. There's plastic ones, and I do have one here today that is plastic, and we talk about what's the difference between these ones. So plastic ones tend to be lighter. Some women will prefer that because they cannot feel it quite as much. Metal ones are actually heavier, so for women who have a little bit more clenching in their vaginal canal, they might actually appreciate the metal ones a little bit more because it helps to weigh down the vagina and helps them to relax the pelvic floor by itself. There are different shapes. There's a Peterson speculum, which is flat and narrow. That's what this one is. And that's better for people who have a narrow vaginal canal. So Peterson speculums are also often used for people who, who have never had a baby, or who are less sexually experienced. Grave speculum, which are the one in the picture that's the third one and the fourth one in the picture, they're a little bit wider and narrower. Those are better for people who have already had children, especially. There's also pediatric speculum, which is the very first one in the picture, and these ones tend to be very short and small, but they can be used on adults. So one of the things that I tend to emphasize here is that it's much better to start off with a smaller speculum and work your way up than to start with a large speculum and hurt the person and then have to work your way down. So you always start small, and if the person, and you can't find the cervix and the patient's like, I can't feel that at all, then yeah, move to a bigger speculum. But why would you start with a bigger speculum? The teaching point here is always have a hands-on practice. So at this point, we start to pass the speculum around and we say, hey, have you tried using a speculum when you're not right in front of a patient? Because that's going to be a time that you really need to learn how to use a speculum. So this is what a speculum is. Notice how it opens. Notice how it locks. Notice that it opens in two ways, both this way and up and down this way. And so with both of those ways, you can get different views inside the vagina and of the cervix. So then for the next part, we talk about setting up the patient before you actually insert the speculum. So asking about those 4 risk factors, and so here we would review again what those 4 risk factors were, which is any history of sexual assault or abuse, any difficulty with speculum exams in the past, any difficulty with tampon use, and any history of pain with sexual contact. The provider should explain the exam, and they can offer self-insertion. There is nothing in the literature that suggests that a patient cannot insert their own speculum. And in fact, that did come up in a legal case back like in the 70s, and it was determined that women can stick whatever they want in their own vaginas. So it is not having the patient practice medicine without a license. They are allowed to insert their own speculum. So you want to correct any myths. Letting the patient know that they can stop the exam at any time. So, and making sure to use the active voice here. So that is not, if you want me to stop, just ask me. Telling them you are able to stop the exam at any time. That actually has a pretty high level of evidence that patients feel less anxious when they feel like they are in control. Letting them know how much to undress. Sometimes, we get very caught up in medicine and we're just like, oh yeah, so just undress and I'll come back in the room. But patients don't know what to keep on and what to take off. So letting them know things like you can keep your socks on, letting them know that will keep them warmer, and it also lets them know exactly what it is that they need to take off. Offering them a drape to place over their lap, but also letting them know that the drape is optional. Some people who are getting speculum exams will find the drape to be a little bit confusing because you're offering the drape to say like, hey, let's cover this up because it might be, because you might want to keep it private, but then I'm going to look under it anyway. So that kind of, double message that we're giving can be kind of confusing for patients. Sometimes patients will be like, well, if you're going to look at it anyway, why do I need a drape? And then I've sometimes seen physicians be like, no, you got to cover up for your modesty. And then, and then that also gives a different message to the patients. Setting up the footrest properly to avoid painful foot knuckling, which is pulling them all the way out. Foregoing the footrest, I still have stirrups on this. I do have a more current edition that actually says footrest. Offering the mirror, as we said, and using a dip tent for the sheet. Then I go on to explain what is dip tenting. So as you can see here, in typical ways of doing a pelvic exam, if the woman is flat on her back and then the drape goes straight across her knees, there is no way for the patient to see your face or for the physician to see the patient and what's going on with the patient. On the right-hand side, you can see here that there is a patient and a physician with the head up, as we talked about in a previous slide, and the sheet is pressed down up against the abdomen. So on in the bottom right-hand corner, you see the patient can clearly see the face of the doctor. Now, this is really important, especially given a lot of the things in the media about physicians sexually abusing during gynecological exams. So you want to make sure that the patient can see the doctor and knows what's going on, and that the doctor can then see the patient's face, like in the upper right-hand corner, so they can see if there's any grimacing, any tearing, anything like that. Then we start to go over what is the anatomy of the pelvis. So again, this is something that you might want to look up on your own and of course with your physician with. And so what we talk about here is that, if you're looking at standing, and then lithotomy is when the person is on their back, looking at how the vagina does not go straight into the body, but it does slope downwards. And so then we go over, how do you actually use the speculum to find that cervix? The cervix is the opening part of the uterus. So what I do at this point is I pass around the speculum and I talk about how do you usually insert this. And we talk about all the different and just the physics of what can happen. Sometimes I will use it with a stocking to show that, to demonstrate how to actually open it. But often I will use my hand. Or a stocking and my hand. What we will talk about is, first of all, that the vagina is not a hole, it's a potential space. So like a sock or a pillowcase, it does not just open all the time, it collapses in on itself. And so that means that you cannot just put a speculum or any other instrument, medical instrument, into a vagina, that it needs to go along, go along the pattern of what the vagina is. So as you can see here, since it slopes down backward, you are inserting down at this angle. The next thing that we talk about is how to open the speculum. And this is something that I have learned is that the posterior, the bottom part of the vagina, is far more flexible than the anterior part, or the part where the part that's more towards the stomach. And so with that, you end up having it with the way that this speculum is. If you press just on this thumb plate, you are pressing up against the part that's most uncomfortable. No problem. Whereas if you use your thumb and pull with your arm like this, you are actually using more posterior pressure, or pressing down against the bottom part. So with that, we talk about how to make it a lot more comfortable for the patient. In addition, we also talk about how that will help to pull the cervix into the opening of the speculum, as opposed to trying to push the speculum in order to see the cervix, which will be a lot more comfortable for the woman. So reviewing again, offering self-insertion, and then before you insert, and this is a part that we do a lot of times, you ask for permission. So you say, okay, I'm going to insert the speculum. Tell me when you would like me to start, and wait for her to start to say, okay. One of the things that I see often is that the resident will say something like, is it okay for me to start? And then they insert the speculum. And of course, the woman is usually like, oh, because they are not ready for that. And so asking for permission and then waiting for a response. Letting the physicians know that they can, and if the patient comes up with any of those risk factors, you want to insert a finger first and gauge the patient's response or discomfort. If a patient can't tolerate a finger insertion or a digital exam, then they are definitely not going to be comfortable with an entire speculum. Allow the patient to decide if the speculum is the right temperature. I let them know that lubricating the speculum is very important and that they should do it for every patient. I have seen when watching a lot of speculum exams as I'm supervising them, some of the physicians started saying like, well, I don't want to lubricate it because if I lubricate it, that could get in the way of the sample that I'm taking. Well, so I looked that up, and it turns out that adding a small to medium amount of lubricant has no effect on the actual sample that you take from the vagina. So then I was able to add that into the teaching as well. We also talk about opening the labia from the posterior, from the bottom aspect, with enough pressure to be able to fully expose the introitus or the vaginal opening. This is to make sure that the provider is not trying to do it from the top, that they're not resting their hand on the pubic bone and clitoris and trying to open the labia that way. Besides that possibly being painful for the patient, that like possibly touching the clitoris of a woman could be misinterpreted or correctly interpreted depending on your intention. But you do not want to touch the clitoris unless that is part of the specific medical exam that you're doing and with her permission. All right, so this gets at one of my teaching points. Use your knowledge of anatomy and pathophysiology. So if you are a health psychologist, then you might have had some courses on anatomy and pathophys. If not, you can take those classes, or you can actually ask to sit in on some of those classes. I've asked, I have asked when I was working on this, can I see the actual pelvic exam training for med students so that I could have a sense of what it was that they were actually learning, that I could gain some of that information. Now, I happen to know all the anatomy and stuff beforehand anyway, because I used to teach psychology of human sexuality undergrad. So I already knew most of the anatomy stuff, but all of these things kind of added to my ability to be able to teach this. Then advancing the speculum, aiming towards the bottom, as we said before, and then taking a really slow time. So telling the physicians to consider taking 30 to 45 seconds for the insertion of the speculum. And at this point, they're all like, what? That seems like a really long time. And we say, if you're thinking about taking a full 30 seconds, you're probably going to actually take 5 seconds. And that is the amount that you should be. So again, thinking of the vagina as being like a sock, or a pillowcase. You don't just drop your pillowcase or your pillow into the pillowcase. It usually takes a little bit of finagling to get it in there. And if you go slowly, it goes in more smoothly. And so that is the same thing as in terms of inserting a speculum. Once the speculum is inserting, asking for permission again before opening the bills, so that the woman is able to adjust how she's feeling, is she's able to say when she's ready. She feels like she's more in control over what's happening. This is especially important for any woman who has a history of sexual trauma. We usually emphasize that for women who have a history of sexual trauma, this can be triggering for a number of different reasons. One of which is that nobody wants to have a speculum exam. So by definition, this is a situation in which something is being put in her vagina that she does not want there by a person in power. So those aspects, which can be very triggering, you want to make sure that she is feeling as in control and as empowered as possible during this. All right, then we go through just another couple of the steps, which I'll go through quickly. Opening the speculum a little bit before withdrawing, because that can pinch the cervix. gradually withdrawing the speculum to allow the bills to close slowly. So emphasizing this, because here a lot of times, again, going back to the physician-centered pelvic exam, they're like, there, I got my sample, I saw the cervix, and then they're fast because they're done and they want to go on to the next patient. So we emphasize here, this is another part where you're going to need to go slowly, because this is a part where you could hurt the patient again. And then making sure to do those last couple of things, helping the patient up out of the lithotomy position, offering wipes to help them clean up. Sometimes we'll give analogy. So I have here the teaching point, emphasize parts that have the evidence backing, which we talked about, and otherwise giving analogies. So sometimes here we'll talk about, like, if somebody was in your home and you were offering them certain, and you had spilled some water on them, you wouldn't just be like, all right, well, I'm on to my next guest. Like, you would offer to help to clean them, like help them clean up. So using analogies to be like, yeah, you know that this would be rude in the real world. Just because you're in this situation does not mean that those are not appreciated. Then we talk about, so that was the typical pelvic exam. When you have a distressed patient or any of the patients who have those risk factors, I go over, because a lot of times physicians will be like, well, why am I going to screen these things? Because what if they say yes? What am I going to do then? So you want to make sure to have that part in there. So a lot of times when we're teaching physicians, we're like, oh, screen for depression. But then they're like, well, what if they say yes? I'm not sure what to do with it then. So you want to always make sure to tell them what to do with a positive screening. So that's what I have here, is when you have a distressed patient, the first thing I have them do is a Valsalva maneuver. So that is having the woman hold her breath and bear down as though she's having a bowel movement. This is actually, it's the same thing that you do when you are having a bowel movement, so it does relax the pelvic floor. Because it's relaxing the pelvic floor, it's counteracting any of the clenching of the pelvic floor that the woman might be doing because she is tense or anxious. I usually encourage them to have them practice this. The patients practice this a few times before they do it during the exam, because the woman might pee on them. So explaining to the woman how to do it, making sure she can do it correctly, and then having her do it during the insertion of the speculum. This is one of the things that I say that the physicians can do themselves. They can teach a patient a Valsalva maneuver. You can also tell the patient to let their legs fall out to the sides. And instead of saying things like, open your legs, which is going to have some sexual connotations, or relax, which we will come back to later. I also tell the physicians they can teach diaphragmatic breathing, and I teach them how to teach diaphragmatic breathing. Now, the rest of these things, progressive muscle relaxation, guided imagery, color, breath work, deep rhythmic breathing, breath counting, and centering, not distraction, those are all things that often I will teach the patient. And so this is where we get into the talk with the physicians about, these are the parts that you do, and then these are the parts that you might want to have a health psychologist do, like either refer to a psychologist or have a health psychologist in the room doing with you. We do talk about distraction and when it's appropriate to use distraction and when it might actually be more harmful to use distraction. The next thing that we talk about are things that physicians frequently do that I tell them to not ever do. So the first thing is to push their thighs apart, no matter how subtle it is. So often you will see a physician, they will have the speculum and they'll be trying to insert, and if the woman starts to experience any pain, she will start to close her legs, and what the physician will often do is use their arm to push the legs apart. First of all, that is going to be both rude and possibly triggering for the woman. But second of all, it's contrary to how the body works. When somebody is trying to force your legs open, your body is going to automatically tense the muscles to close the legs back because you're creating that resistance. So it's actually going to increase tension on the pelvic floor. So you never actually use your body to push legs apart. You use words instead. The second thing that I have is, don't tell your patient to relax. At this point, I usually pick out some people in my audience, and I'm like, I want you to feel angry. You feel embarrassed. Do you have those emotions on command? No, of course not. We don't have emotions on command. So telling a patient to relax is not going to be effective. In fact, it's going to make them less relaxed because they are not going to be able to do what you're saying. They're not going to be able to follow your command. They're going to get more tense. So instead, tell them what it is that you want them to do. So, for example, if you do notice that they are starting to clench up their body, tell them how to do a diaphragmatic breath, or tell them to do a Valsalva maneuver. Tell them, okay, what I want you to do, what I'm going to ask you to do right now is hold your breath and bear down like you're having a bowel movement. And then when they do it, tell them that they're doing that's the maneuver that you wanted them to do, and say like, okay, you did that correctly. Do not ever force the insertion when the vagina is contracted, and do not ever continue the exam when the patient says stop. Again, a lot of times people say like once the patient starts to say stop, or they're like, well, I'm almost there, let me just finish it up real quick. That is not acceptable. That is doing a medical procedure after the patient has withdrawn consent, and that has very big medical legal consequences. So I tell them to not do that. Other things that I usually talk about at this point is like, don't go at a pace that is faster than what the patient is comfortable with. And interestingly enough, I've had to add other things onto here, like don't leave a speculum inside a patient while you go to talk to your supervisor. Unfortunately, I keep seeing that happen. And that is, and sometimes residents will say things like, oh, well, it was really hard to insert that speculum and I didn't want to lose what I was looking at. And I always go through the pros and cons, like, is that going to harm the patient? And the likelihood is yes, that's probably not the best idea. And yes, it's going to put you behind on your schedule. All right, the next thing that in terms of teaching is to create a pocket card. So we created this pocket card, and so it's like a little trifold. We can print it out on like 8.5 by 11 paper, and it goes through all of the main points that we go through. So you can see here on the second one, the one on the right, it's got the screening questions right there. So it's got the, how do you actually word the sexual history question? How do you actually word the sexual assault question? So that after they've gone through this whole thing, that they have something that they can take into the patient's room with them and use as a cheat sheet. Then we have it set up again in the same order as the medical visit. So setting up the patient, using the speculum, tips for the distressed patients are all on there. Then what me and the other Dr. Williams, we are not related, what we did is after we created this curriculum, we wrote it up as a full article and we published it in Teaching and Learning in Medicine. So this is kind of, if you want to go that extra step. So the pocket card is actually what most people are going to use, and most people are going to implement immediately. But then when somebody's like, oh my gosh, that was so helpful, do you have more details, not just what's in the pocket card? Then you can say like, hey, we have this full article where you can read through pretty much everything that we just said. Now, the downside of the article is that, that came out in 2013. There's already things that I would definitely change about what I put in that article. Not all of the things, but there are definitely like a few things where I'm like, I wish, now that's not such a great idea. And so we might do like an updated one in a few years. Add any special, this is just a special thanks to Dr. Bruce Ganeshan, who also helped with us. So we also paired with an OBGYN. And again, the more that when you are teaching outside of your field, if you can pair it with anybody who is in any of the fields that you are trying to teach, that will also lead you, give you some credibility as you are doing it. Now, when I do this now, so me and Dr. Williams used to give this presentation together. Then eventually I just started giving it on my own. I was first author, so I had written most of the teaching myself, but I have now been doing it on my own for a number of years. And thankfully, I have actually gotten a lot of feedback. And in fact, literally, and I just have some references here, literally, let me pull this up over here. This was, what's today, Wednesday? Mm-hmm. So literally yesterday, from one of my former residents who is now an attending, she sent me this text that says, she says, I just gave another patient-centered pelvic exam 5-minute feedback session to a resident. So this is basically one of my residents who's now an attending who gave my teaching this thing to another resident. And she said that resident was like, OMG, this has changed my life. So that makes me extremely happy. That means that, like, you know, at a certain point, like when you're doing this type of teaching, it is, it continues to, you know, not only are the physicians using it themselves, but they are spreading it to other physicians, and it can continue to affect and hopefully make a lot happier. So my residents now call this the happy PAP, and just making pelvic exams a lot less difficult or problematic for a lot of our patients. So now with the last few minutes, thank you very much. This is my email address if you do have any questions. And I want to be able to answer any questions that you guys came up with.
Thank you so much, Dr. Williams. That was really interesting. Oh, can you repeat the phrasing about
history of sexual?
Yeah.
Yes. So for history of sexual abuse and assault, I actually use 2 separate questions. The first question I ask is, has anybody ever had you do something sexual that you did not want to? Okay, so has anybody, you know, just basically had you do something sexual that you did not want to? The second question that I ask is, has anybody ever touched you in a way that made you feel uncomfortable? That's the full thing. Has anybody ever touched you in a way that made you feel uncomfortable or had you do something sexual when you didn't want to? With children, so if you're ever doing screening questions for children, usually I start a little bit differently if you do have to do any kind of genital exams for children. So with children, depending on the age, we might start with, you know, what, like naming body parts, like what, you know, what's this? And they say eyes, and I say, like, what's this? And they say arm, and we go through body parts, and I'll say, what do you call the parts of your body that are covered with bathing suit? And then whatever words they use, that's the word that I will use. So if they're like, that's my down there, or that's my privates, then we'll use that word. And I say, okay, well, and who's allowed to touch your privates? Or who touches your privates? And, you know, and they might say nobody, and then I'll be like, well, it's not nobody. You're allowed to touch them. Who else is allowed to touch them? So you're kind of normalizing them, letting them know that it's okay to talk about them. And they might say, like, you know, mom or dad does when they're cleaning them, and, you know, and so we'll, you know, or when they're wiping me, or things like that. So we might start off the conversation like that. And then we move on to, okay, has anybody ever, you know, besides that, has anybody ever touched you in your privates? And then we also add on, has anybody ever asked you to touch them on their privates? So those are the 2 questions that I tend to ask children. And then as the, you know, depending on the maturity level, as the child gets older, we might add things on. And, you know, if they know what sexual means, then we'd be like, you know, have you ever felt pressured to do anything sexual? Has anybody had, and then move into, has anybody had you do something sexual when you didn't want to?
I think that was the only question in the chat box. Let me just double check.
Any other questions?
I think that was it. Well, thank you so much, Dr. Williams, and thank you everybody who tuned in today. Oh. Have you ever thought about applying this to other areas in OB/GYN?
Besides so that is a fantastic question. Yes, I definitely have thought about using this in other areas of OB/GYN. One of the things that I have found so far is I think that only one department actually in OB, like only one OB-GYN department has actually allowed me to give this training. Usually it is family medicine and internal medicine. OB-GYN often, OB-GYN often feels like they know how to do the pelvic exams very well. I can, so, and I just got another question too, so I will answer that. There are some people who do specialize in OB-GYN. There are definitely ways of doing this for a lot of the things in OB-GYN. So everything about, pregnancy and childbearing and all of that, like there are, so this, I just am doing this. This presentation is on patient-centered pelvic exams. When I teach family medicine residents in general, we will talk about all different types of physical exams. So I am in the room with the patient, with the physician and the patient, and I just watch, like, what is the patient's reaction and what is the physician doing. So sometimes we will even talk about applying things to just like, how do you listen to the heart? And because sometimes I will see the physician just like, like reach up somebody's shirt to put the stethoscope on their chest, and I'll be like, okay, well, how do you think that the patient might have perceived that, and that might have felt kind of weird. Just doing any kind of exam. So we actually do apply this to a lot of physical exam things, including throughout the OB experience. There's been a couple times when I've been invited to actually participate in a delivery, especially for people who have vaginismus and who are very scared about the delivery. So far, I have not had the opportunity to actually be in the room for the delivery. Usually they happened and I didn't get called, even though I was like on call, they did not call me for it because they said like, oh, the patient ended up being fine and didn't ask for it. But hopefully that will be something that we do. But yes, absolutely, like there are lots of physical exams that you can apply these to, not just pelvic exams. That's just the place that I started. There's also a question about whether or not these slides are available. Now, is there a way to send out the slides?
Yeah, so if you all, hi, this is Aviva. If you email me that you're interested, I'd be happy to disseminate them as long as that's okay with you, Dr. Williams.
Yes, and also, as I said, the that article, which is in Teaching and Learning in Medicine, and that is called, let me go, oh wait, can I go back here? The article is called A Guide to Performing Pelvic Speculum Exams, a Patient-Centered Approach to Reducing Iatrogenic Effects. That is in, so that you can also just search for that and get kind of like almost everything that I just said, plus a little bit more. The article also goes into some things like, what are some body postures that you might observe in the patient while she's up there? Like if her hands are on her chest, that means some, like that might mean less distress than if her hands are on the sides of the chair, and ways of noticing like what types of things might actually mean silent distress in the patient. So those are some things that are also in that article. All right. I think that's. Any
More?
Oh yeah, any hypotheses about why family medicine might be more open to this type of teaching than OBGYN? Well, family medicine is actually required by ACGME, which is the governing body for residencies, to have behavioral medicine as part of their training. So every family medicine residency has some behavioral medicine person on staff. Often it is a psychologist and a health psychologist. Sometimes it is a psychiatrist or an LCSW, a social worker. So family medicine does tend to be just overall as a field to be very open to behavioral medicine teaching, whereas OBGYN sometimes has some behavioral medicine, but they are not yet required. So a lot of times that is not just part of that culture yet. My hope is that eventually all residencies will be required to have behavioral medicine integration. All right, any other questions?
Great. Well, I seriously cannot thank you enough on behalf of everyone here at Jesse Brown and Northwestern. That was such a unique presentation that I've never seen before, and I think it really does kind of give us ideas as trainees of how behavioral health and health psychology can kind of fit into different disciplines. So it was great.
Yes, thank you guys so much. I definitely want to spread more words about this. So because the fewer people who get traumatized by exams, the better. I definitely don't want people with vaginas to suffer any more than they need to. So or anybody to suffer more than they need to, but definitely not with just like having that exam. So thank you so much for allowing me to present to you.
Thank you, everyone. Bye-bye.